In the previous session, we have discussed the cerebrum, the biggest part of the brain, but we couldn't finish on the sensory and motor areas of the brain, and I think this is a perfect moment to do so. What's up, ladies and gentlemen? Welcome back to Neurosketch with Dr. Ken. But if this is the first time you're seeing this channel, don't forget to subscribe. Today, we're going to talk about the sensory and the motor area of the cerebral cortex, the sensory and the motor areas of the brain. And just to remind you, the cerebral cortex is the layer of gray matter, and we say this is the functional area because it contains neuronal cell bodies, and it's a functional area of the functional layer of the cerebral cortex. So we have this guy who's called Corbinian Brodmann. So in the year 1909, this guy, Corbinian Brodmann, sliced the brain in the 52 cytotectonic areas, and he assigned them numbers. Yeah. So he took for the first time he took this one, he called number 1, and then he later came to take number 2, and then number 3, number 4, number 5, number 6. He was just taking this slice randomly, and then he went to learn them under microscope. Then it turns out that many areas identified by this guy, Corbinian Brodmann, they fairly correlate with the other functional areas of the brain. For example, this guy discovered that area number 1, number 3, 1 and 2, they are all taking part in a primary somatic sensation. So they have something in common. If that is not enough, he also discovered that area number 41 and 42, they have something in common. They are all taking part in a language processing. Then this guy came to conclude that okay, in these 52 areas of the brain, there are some areas that have something in common. So you have groups of areas, group of different areas. Now the cerebral cortex can be functionally divided into 3 groups. Functionally, one more time, functionally divided into 3 groups. Yeah, you have the sensory areas, you have the motor areas, and the association areas. And the general rule is easy. Like the sensory area, they are receiving the sensory information, they interpret it. Okay, the motor areas, they are initiating movement, motor for movement. And the association area, they are dealing with the more complex integrative functions, things like memory, memory, emotions, reasoning, judgment, will, personality traits, and different intelligent function. And this is how the whole cerebral cortex is organized, yeah, into sensory, motor, and association areas. Yeah, so the primary sensory and the motor areas, primary sensory and primary motor areas. So the primary motor area is easy. We say the primary motor area is sitting in the precentral gyrus, a gyrus before you go to the central sulcus. And we say this primary motor area is the Brodmann area number 4, region number 4. It initiates movement, yeah. And then we said we also have primary somatosensory area, which is post-central gyrus, which is Brodmann area number 3, 1 and 2. If you guys you can remember 3, 1 and 2. And this is dealing with the primary somatic sensation, somatosensory. But the primary sensory is not limited to somatic sensation. We're also dealing with those spatial sensation, the sense of vision, sound, taste, balance, and hearing are also being done, but they are not done by the primary somatosensory area. They have their different areas, and we're going to discuss them each one in turn. Okay, so something easy to remember about the primary motor area and the primary somatosensory area is the primary motor area is anterior to the central sulcus, and the primary somatosensory area is posterior. So it has the same orientation, the orientation of the spinal cord. Remember, in the spinal cord, the motor root is on the ventral side, and the dorsal root is the one that is dealing with this sensation. So the sensor is posterior in the spinal cord. Remember the spinal cord, the somatic. Remember the spinal cord, the sensation from posterior root, which is the dorsal root, and the motor is the ventral root. Yeah, same applies here in the primary motor and somatosensory areas, in the Brodmann area number 4 and the 3, 1 and 2. Okay, let's discuss about the sensory areas of the cerebral cortex. Again, the sensory areas of the cerebral cortex can be divided into 3 groups. Yeah, you have the primary sensory areas, secondary sensory areas, and the sensory association area. And the general rule is simple, because the primary sensory areas, they are receiving sensory information, but the sensory association area together with the secondary sensory area, they are interpreting this received information to make sure they are generating the meaningful pattern of recognition and awareness. And I gave you an example last time and I gave you an example the other time. If you have damage to the primary visual area, which is one among the primary sensory areas, you can be blind at least in a part of the visual field. But if you have damage to the visual association area or the secondary visual cortex, you might be able to see but yet not be able to recognize a friend, because you cannot interpret in what you are seeing. Yeah, because the sensory association areas together with the secondary sensory area are the one that are interpreting and generating the meaningful pattern of recognition. I think that's is very clear. Okay, next let's talk about the primary somatosensory areas as one among the sensory areas of the brain, because we've divided the sensory areas of the brain into primary sensory area, secondary sensory area, and the sensory association area. And in this discussion, we want to deal with the primary sensory areas, and we will spare this higher cognitive, higher integrative function of the sensory areas. Okay, so the primary somatosensory area, remember, is the Brodmann area number 3, 1, and 2, and not 1, 2, 3. And this is because this guy was taking slice just randomly, but when you want to number them, when you want to number these Brodmann areas, you are starting from proximal to distal, from the rostral to distal. And if you remember, this is the rostral part of the cerebral cortex of the cerebrum, and this is the caudal part. Yeah, so when you're starting from here, you are encountering number 3 before you go to number 1, and then you go to number 2. So always remember, is Brodmann area number 3, 1, and 2, and not 1, 2, 3. Okay, yeah, so this region is found in the post-central gyrus. Remember, post-central gyrus. And one more time, we said the right side, I told you the other time, the right side of the brain is dealing with information from the left side of the body, or the right side of the brain is interpreting or is commanding the left side of the body, and the left side of the brain is interpreting the right side, is interpreting and controlling the right side of the body. We're going to talk later when we're doing the anatomy of the brainstem. Why does it happen? Of course, this is due to closing of fibers at the lower border of the medulla, which is called a medullary decussation or pyramidal decussation. But don't worry about pyramidal decussation, because we have a separate session. I'm not going to talk about it. But at this moment, you just know. So, the primary somatosensory area is receiving somatic sensation from the contralateral side of the body. Okay, so if this is the right side, then this primary somatosensory area is receiving the information, the somatic sensation, from the contralateral side. And we said, what are these somatic sensation? You said you have temperature, touch, pain, proprioception, itch, tickle sensation. Yeah, and we are excluding the spatial sensation. They are not covered within the primary somatosensory area. So what is it? What is the repercussion? Yeah, what is the implication? What if you get damage to this region, the primary somatosensory area? You might not be able to receive this somatic sensation from the contralateral body side. Yeah, for if you have injury to the left primary somatosensory area, then you might not be able to feel from the right side of the brain, of the body. Okay, so let's now talk about the somatosensory homunculus. Okay, so the word homunculus actually means little man, and each region of the body is being mapped to the brain. Each region of the body is being mapped to the brain. And if you want to be specific, for somatosensory homunculus, each region of the body is being mapped to the primary somatosensory area. And remember, the primary somatosensory area is the post-central gyrus. That means each region of the post-central gyrus, this is the post-central gyrus, coronal section of the post-central gyrus. Each region of the post-central gyrus is being assigned to take care of the sensory information from the specific part of the body. For example, this region over here has been told to take care of the information that is coming from the face. This region over here is told to take care of the information, of the sensory information that are coming from the arm. This region over here is taking information from the sensory input from the trunk. This over here from the limb. This over here takes information from the genitals. This region over here, this region of the primary somatosensory area of the post-central gyrus is taking information, is receiving the sensory input from the tongue. Yeah. So these This mapping is what is known as the somatosensory homunculus. So that means if you have damage at this region, you might not be able to feel from the face. Yeah. If you have damage at this region, you might not be able to feel from the trunk. If you have damage at this region here, you might not be able to feel from the lower limb. But always remember, it is the contralateral side, because we've said the lefty somatosensory area of the lefty cortex is receiving information from the right side of the body, so you might not be able to feel from the contralateral side, and this is what somatosensory homunculus is. But two important things to make clear here. Number one, as you are moving toward the lateral side of the primary somatosensory area, you are moving more toward the upper part of the body. This is to say, the upper part of the body have been represented more toward the lateral side, and the lower part of the body have been presented more toward the medial side of the primary somatosensory area. And this is why you have the lower limbs on the medial side, but the face are more to the lateral side. Number two, you see you have different sizes. For example, the face is being represented higher than even the trunk, but in reality the trunk is bigger than the face. This is also very important to note, that the size of the body part in the somatosensory homunculus, they do not corresponding to the actual size of this body part in reality. Yeah, because in reality the trunk is bigger than the face, but you see the face is highly represented in the primary somatosensory area. Same applies, the arm is highly represented, at least the hand is highly represented. So the size of the body part in the somatosensory homunculus, they corresponding to the density of sensory receptor, to the density of sensory receptors. Those regions of the body which have got a dense sensory receptor, they are being represented higher in the primary somatosensory area. For example, the face has got a lot of sensory receptors. This is why it's been represented higher than the trunk. The trunk has got few number of sensory receptors compared to the face. This is why the face is highly represented. Look at the lips. Yeah, the lips are highly represented because the lips are very sensitive. Yeah, even if you are asleep and then an insect crawls along your lips, you can feel it. Yeah, even on the palms. Yeah, the palms are very sensitive. Even if you draw something, even if you are asleep, someone touches you, you can feel it. Yeah, even also the soles of the foot. But it's hard for the trunk. The trunk is usually not that sensitive, because has got no enough number of sensory receptors, or no dense sensory receptors compared to these other parts of the body. And this is how the sensory homunculus is being organized. The somatosensory homunculus is being organized, and I hope that is clear. Yeah, so the size the size of a body part in the somatosensory homunculus, it is corresponding to the number of receptors that are present in that organ or that region, and not the actual size of the body. This is very, very important. Yeah, so those regions with high density of sensory receptors, they are being represented much in the somatosensory homunculus. So the major function of the primary somatosensory area is to pinpoint the areas where the sensation is originating. For example, you feel like a mosquito is biting you at some area, maybe at your face or at your leg, and then you want to swat at it. Yeah, so the primary somatosensory area is telling you, okay, this thing is biting you at this point, maybe left lower limb or left knee or somewhere, and then you act upon it. That is our primary somatosensory area. And if you guys remember, if you're doing advanced biology, you remember in the book of BS biological science, there's a picture like this one. Yeah, so this is the primary this is the somatosensory homunculus. These regions which appear high bigger here, they're actually bigger because of the presence of a dense number of sensory receptors, and these small parts here, which are not much represented in the somatosensory homunculus, means they have a low number or low density of the sensory receptors. Look at the lips one more time. Yeah, the lips are highly represented because they are receiving they have a dense number of sensory receptors, and so they are very, very sensitive. The face in general is very, very sensitive. The palms, look at the palms, they're very sensitive, but the trunk very small, the arm very, very, very small. So that is a primary somatosensory homunculus. Now let's talk about the primary visual area Okay, let's now talk about the primary visual area. Okay, we said the visual cortex is the occipital lobe. Occipital lobe is the one that is primarily dealing with the visual information. And the primary visual area is the Brodmann area number 17, which is at the pole of the occipital lobe. And this we said is dealing, the primary visual area is dealing with the visual information, and the vision is also sensation, but it's a special sensation. Okay, so the Brodmann area number 17 is the primary visual cortex, and this is the receiving the visual information. It sits on the bank of the calcaline fissure. So this is the calcaline fissure, and the calcaline fissure has got two banks. I mean, it's between two banks. It has the upper bank and the lower bank. So this is the upper bank of calcaline fissure. This is the lower bank of calcaline fissure. Of course, don't worry, we're going to discuss the visual pathway, and we'll talk again about the primary visual area, or the primary visual cortex. And something to keep in mind is these one are receiving the information from the contralateral visual space. And don't worry, don't attempt to understand what a visual space is at this point, because it's sometimes confusing, and we'll have a separate discussion. Then why will you bother yourself too? Okay, and the primary auditory area is the Brodmann area number 41 and 42. Brodmann area number 41, number 42, they are primary auditory area. What does it mean? They are involved with receiving the auditory information from the auditory receptors. Yeah, because primary, they are receiving. Secondary and association, they are interpreting this auditory information. And the primary auditory cortex is composed of these two gyri, which are called the transverse gyri of Foelski. Yeah? So the function of the transverse gyri of Foelski is auditory information. They are primary auditory cortex. Okay, and you can see this primary auditory cortex, which is the transverse gyri of Helsky. This name is hard for me to pronounce. It is deep within the sylvian fissure. So this one here is the sylvian fissure. Let me show you. This is the sylvian fissure, and if you try to separate the sylvian fissure, you can see this transverse gyri, which are called the transverse gyri of Helsky. I think this guy was somebody like, I think was German, this name, I think. Okay, the information reaching the primary auditory cortex is usually less lateralized. It's less lateralized, and it represents a mixture of input from both ears. And usually one ear is contributing, the opposite ear is contributing much than the ipsilateral ear, but this is usually not clinically detectable. One more time, the primary auditory area is the Brodmann area number 41 and 42, and the function of this primary auditory area is to receive the auditory information, and this auditory information has to be interpreted at some point, and they're being interpreted by auditory association areas. Yeah, auditory association area and secondary auditory cortex, for example. So this is the auditory association area, and what is the function of the auditory association area is interpreting the auditory information. I'm taking you back. These were the primary auditory area, Brodmann area number 41 and 42. They are receiving the information. But the auditory association area, which is this region over here that I haven't talked about yet, is called the Wernicke's area or Wernicke's area. It's Wernicke's because this guy was German, and in Germany, W is V. So it's Wernicke's area because the guy was Germany, or we can just call it the Wernicke's area, which is the Brodmann area number 22. I haven't talked about it yet, but I am about to talk about it. This Brodmann area number 22, which is the Wernicke's area, it is the auditory association area. This one deals with interpreting the auditory information. For you to be able to understand what someone is saying, yeah, the language comprehension, for you to be able to understand what is someone talking about, you need to have this area intact. Yeah, for you to be able to make sense of what you are talking, you need also to have this region intact, which is Brodmann area number 22. If you have damage to this region, you're not going to be able to make sense, yeah, both by reading or by talking. So this region here, it is usually on the posterior surface of the superior temporal gyrus. This is the superior temporal gyrus. On the posterior surface, you have the Wernicke's area, and it's usually found in the dominant hemisphere. And we said To majority of individuals, the dominant hemisphere is the left hemisphere. So me, you and I most likely will have our dominant hemisphere on the left side. So if you have damage on the left cerebral hemisphere, if that is your dominant, for example me, I think because I'm a right-handed, then most likely I'm going to have my dominant hemisphere, which is the left side. I might not be able to make sense of what I'm talking or what I'm listening from people talking. Okay, so this is called the language comprehension. This region is responsible for interpretation and the comprehension of written and the spoken language. If I have damage to the left hemisphere, which is dominant to me, and have damage, for example, to this region, which is the Wernicke's area, Brodmann area number 22, I might not be able to understand what people are talking. Or myself, when I want to talk, I will talk something that doesn't make any sense because I don't have that part to that is responsible for interpretation and comprehension of the written and the spoken language, and that's Brodmann area number 22. We're going to see it later. So damage to this region results in fluent but receptive aphasia. Is fluent in such a way that someone is talking freely and fluently, but he or she is not understanding what he's talking about, or is not understanding what someone is telling him or her, or is not understanding the written language. Yeah, so language comprehension, or given a paragraph, you cannot understand what it means. That is that is auditory association area. Okay, I've emphasized it a lot because we can have a lot of questions that are coming from this area, which is the Wernicke's area or Wernicke's area, Brodmann area number 22. Okay, so we have the primary. We've gone back to the primary. This was the association. One more time, I remind you, this was the auditory association area. Now we're going back to the primary area, which is gustatory sense of taste. So the sense of taste is actually easy, which is Brodmann area number 43. This one is receiving the sense of taste. Yeah, sense of taste. Yeah, so it's right over here at the base of the postcentral gyrus. Remember, the postcentral gyrus is Brodmann area number 31 and 2. So just at the base of the postcentral gyrus, you have the Brodmann area number 43, which is the primary gustatory area. So it receives the taste and it's involved in the gustatory perception of taste. You feel something is sweet or something is maybe bitter or something, it is just because of this primary gustatory area. And we're not going to dive into details of other sense modalities. I mean, we've just I think we've exhausted it enough. So let's now go to the motor areas. And the motor areas is easy. Though these are the ones that are doing the movement, yeah? Doing the movement. Also, the motor areas are divided into primary motor area and secondary motor areas, yeah? But today we're only dealing with the primary motor area. Talked about 1,000 times. We've said the primary motor area is sitting in the pre-central gyrus, a gyrus before the central sulcus, and that is the Brodmann area number 4. And we've said these motor areas, they are controlling the movement of the contralateral body side, yeah? So for example, if you are on the right side, the right precentral gyrus is controlling the movement of the left side of the body, and they've said at least just that is because of crossing over of fibers at the lower border of the medulla, which is called the medullary decussation or the pyramidal decussation. We'll have a separate discussion on the brainstem. I think you can always check it out. Okay, so let's see the motor homunculus. Same as how we had the sensory homunculus, we also have the motor homunculus, and the idea is the same. Like different parts of the body have been mapped to the brain in such a way that in the primary motor area, every part of the precentral gyrus is being assigned to take care of movement of a specific part of the body. For example, this region over here of the precentral gyrus is taking care of the movement of the face. This region over here is taking care of the movement of the hand, movement of the arm, movement of the trunk, and the movement of the lower limb. Okay, and then this region over here is taking care of the movement of the tongue. Okay, easy. That's the primary, that is the motor homunculus. But something to make very clear here again is, of course, as you're moving from the lateral side, from the medial to lateral side, you are going to the upper part of the body. But as you're moving from to the medial side of the precentral gyrus, you are going to the lower parts of the body. But as in sensory homunculus, the size of the body part in the motor homunculus, they do not correspond to the actual size of the body parts in reality. For example, in reality, the face is not huge than the trunk, yeah? And you see in the motor homunculus, the arm is actually higher represented than even the lower limb, yeah? But in reality, the lower limb, the leg, is actually longer than the arm, but the arm is highly represented. Look at the hand. The hand is highly represented. Yeah. So the size of the body part in the motor homunculus is actually corresponding to how skillful, delicate, and complex the movement is formed by these muscles are. For example, the face is able to form a complex movement compared to the trunk. And if you guys remember, what are the movements of the trunk? They are just very common, like have just a flexion, extension, lateral flexion, and rotation, period. Yeah? Is this movement skillful? No. Is this movement delicate? No. Is this movement complex? Not at all. But look at the face. The face is highly represented because the face is able to make complex movement, because we've seen the trunk has got maybe 4 movements, but the face has got a number of movements, yeah. And they will say that on average, a human being can have more than 10 facial expressions. Like if you blow your cheeks, is different expression. If you raise your eyebrows, different expression. If you wink, it's a so these are the skillful, complex, and delicate movement. Look at the hand, for example. Yeah, the hand is highly represented than even the trunk, even the lower limb, because the hand is able to make different delicate movement, yeah, to line between lines, yeah, and you want to line between lines, yeah, you line a straight line. This is not so easy, yeah. It requires the skillful and the delicate movement. Look at those people who are operating on the they are operating on the very, very delicate tissues like your brain or the heart, yeah. So they are very, very fine in movement, and this is because the hands are highly represented. Of course, they have some training that are training these hands, they are training these parts of the body, these parts of the brain. But this is to say the hands are highly represented because of how complex. Look, someone can draw a picture, a very beautiful picture, yeah. So this is how complex and delicate the movement is formed by the arm is. And this is also why the basketball is easier than football, yeah, because you see the basketball, the hands are highly represented the cerebral cortex, and it's easier for you to to, I don't know, is it to range or something, but it's hard for someone to take a penalty, for example, or free kick, for example. If you guys watch football, you understand even those skillful players like Messi and Ronaldo, they're not very sure when they want to take a free kick, they're not very sure that they're going to put that ball at the back of the net. Even to put them on target is sometimes difficult, yeah, because the foot is not very accurate, because it's not well represented in the somatosensory, in the motor homunculus than the like the arm. And this is why even those are doing basket, it's easier for them to range because they are relying on hands, and hands are highly represented. And this is also it makes sense because you see the goal of basketball is actually small. Is small because they are very sure that, okay, if you are relying on hands, you're going to put the ball on the net easily. But for football, the goal is very huge because they are very not sure if you're going to put, if you are shooting from a distance, you're not going to put this ball within the target. Okay, so this is the motor homunculus, and you see those regions, the more cortical areas are devoted to the muscles that are involved in skilled, complex, or delicate movement. And this is why you see the hands are represented, because you see you can have different movement that can be made by here. Remember, when you are lighting, yeah, you can light different, you can shape, you can twist your hands into different direction to write different, a thousand of different words, yeah, a thousand of different words. So if you have damage to the primary motor area, which is the precentral gyrus, you have weakness or paralysis. It can be weakness if it's it's a mild damage, but if it's a severe damage, you can have paralysis of the contralateral. This is the key. contralateral body part because of the crossing over of fibers. But as they say, as we have said, we have this is just a primary motor area, but we also have the secondary motor areas like the premotor cortex and the posterior parietal cortex. These are the like secondary motor areas. Okay, so this is the tongue. You see the tongue is also highly represented because you can twist your tongue into different directions to speak 1,000 of words. So you are able to speak today just because your tongue is very skillful and has got a complex and a delicate movement. This is why also it's a little bit highly presented. You can see it's huge in the motor homunculus than even the trunk, because it has got a number of movements compared to trunk. I would say it has got no skillful movement. It just have a basic movement, flexion, extension, and whatever. But the tongue, a thousand of movements. I mean, that is literally, I'm exaggerating a bit, but it has got a number of movements. Okay, so let's talk about something very important, which is called the cerebral palsy. Cerebral palsy is the neurological disorder that affects movement, posture, and coordination. But most important is this disorder is due to the damage in the developing brain, both before birth, during birth, or shortly after birth. So if you in this critical period, if you have any insult to the brain, any insult that is potentially damaging the brain, it can result into cerebral palsy. And what is it? This one affects, it's a neurological disorder that affects movement, posture, and coordination. These are the potential causes of cerebral palsy. You have radiation during fetal life, radiation like X-rays and CT scan, and this is why you tend to avoid CT scan and X-rays to a pregnant lady. When a pregnant lady comes to you as a doctor, you tend to avoid CT scan and X-rays because among other complications, it can result into cerebral palsy, damage to the baby's brain. But birth asphyxia, which is actually a lack of oxygen during birth, it can result into ischemic damage to the brain, and so it can result into the cerebral palsy. Because remember, we've said anything that is potential of causing damage to the developing brain, it can result into cerebral palsy. And remember, the brain develops, is fully grows at the age of 7 years. So if you have damage in between here, you can potentially damage. But the cerebral palsy is either before, during, or shortly after birth. So you have hydrocephalus during infancy. It can also result in cerebral palsy, and ideally any insult to the developing brain can result into cerebral palsy. So these are the clinical manifestation. A baby can have one or a combination of these symptoms or signs and symptoms. So they can have impaired movement. As we've said, this is a disorder of movement. But posture, exaggerated reflexes, the floppiness, they can be floppy or spastic, like they have the very spastic muscles. They can have unusual body posture, like involuntary movement and instead walking, and we've said you can have combination of these movements. Of course, we'll have a separate session on the cerebral palsy, but this is just a highlight. And signs and symptoms usually appear during infancy. The infancy is the period of 1 year of age. I mean, within the first 12 months of life, that period is called the infancy. So during the infancy is when you can have some of these symptoms witnessed. And of course, this baby can also have problem with the swallowing because of uncoordinated movement of the muscles of the pharynx. And why are we doing cerebral palsy at this point? We are doing cerebral palsy because this is a disorder of movement. It's a neurological disorder that affects movement, and we've just discussed about the motor system. We've seen the motor homunculus. So if this inside the developing brain is damaging the part of the motor homunculus, then we know the child will have presentation to the specific part which is represented by that part of the motor homunculus. Of course, these babies can also have intellectual disabilities depending on the severity and the extent of damage, because at this moment you know what part of the brain is involved with intellectual capabilities. So if you have damage to those regions, can result into intellectual disabilities. And these are some of the movement disability. This one is a spastic movement. You can see some of the muscles that are spastic, and so the child or the kid is walking and spastic, and that is one among the spastic part of the spastic type of the cerebral palsy. We'll have a separate discussion that we're talking about the cerebral palsy, but we'll have different clinical manifestation. This is also kind of spastic, but this one here is this kinetic kind of we're going to talk about these types of cerebral palsy at some point. Now let's talk about the motor. These were motor, primary motor areas. Let's talk about the motor speech areas. Yeah, motor speech area. Now the motor speech area is also called the Broca's area, or the Broca's speech area, which is the Brodmann area number 44 and 45. Yeah, so Broca's speech area is somewhere here, and this region is found in the frontal lobe, and if you want to be specific, is the inferior frontal gyrus. Yeah, this is the inferior frontal gyrus, and this is the motor area. That means it is dealing with the planning and the production of speech. Planning and the production of speech. Remember, the speech can have both the sensory part and the motor part. The sensory part, we've already seen it in the primary auditory area. Yeah, it's receiving the information, but we have seen the auditory association area, which is Wernicke's area. This region here, Wernicke's area, which is Brodmann area number 22. This is dealing with interpreting, yeah, and understanding the written and the spoken language. But planning and the production of speech is done by the motor system. Yeah. So simply, the primary auditory area will receive the auditory information. The auditory association area, which is also called the Wernicke's area, will interpret that information in both the written and the spoken way, and the Broca's speech area will plan and produce a speech. This is how the speech is organized. That you are receiving, you understanding what someone is saying, you are receiving the information of something, and then you understanding what is being said, and then you are replying back. Yeah, you are replying back. Okay, so this is your Broca's area, and okay, planning and the production of speech occur in the left frontal lobe in most of people, and this is the flow of information. The information is coming from the Broca's area because this is the one that initiates, and from the Broca's area, the information goes to the premotor area. The premotor area is like the secondary motor area, and this one controls the muscles of the larynx, pharynx, and the mouth, because these are the ones that are helping you to produce a speech. Okay, then this will result into coordinated muscle contraction. But at the same time, the information from the Broca's area goes to the primary motor area, this region over here, and then this information will result into regulating the breathing muscles. Yeah, so to be able to regulate the proper flow of air past the vocal folds. Remember the other time we discussed about the mechanism of speech, and we said the sound we are producing is actually the air which is coming from the lungs. Air from the lungs is getting to the vocal folds, it's being vibrated by the vocal folds, and then push it to the mouth, and then in the mouth it finds the tongue, and the tongue is, articulating, is moving in different direction to push this air which is coming from the lungs to form different words. This is shortly the mechanism of speaking, or of speaking. And this is to say that the process of speaking, it involves both the speech areas, but it also involves these muscles, the muscles of the larynx that are vibrating these vocal folds, the muscles of the tongue that are keeping the tongue in different direction to produce different sounds. Yeah, so this is the coordinated contraction of your speech, and the breathing muscles enable you to speak your thoughts. You are speaking your thoughts. Okay, damages of the Broca's area, it will result into non-fluent aphasia. And in non-fluent aphasia mean the person will not be able to talk fluently. He will have breaks. Yeah, he will struggle to form words because maybe there is an coordinated contraction of these muscles, different muscles that are helping him to speak. And the Broca's aphasia commonly occur in stroke. And remember, in stroke, people have mouth deviation. And if you have mouth deviation, you'll not be able to articulate. Yeah, now you understand the mechanism of speaking. Like the muscles of the mouth are not properly coordinated, and so the person will struggle to form words. And this is the key in Broca's aphasia. Like the person is struggling to form words. Yeah, this is why it is called a non-fluent. Like the person cannot talk fluently. Yeah, he has puzzles. Puzzles within when he's talking. Okay, is also known as the expressive aphasia, because Broca's area will help you to speak your thoughts, and if you have damage to the Broca's area, you will not be able to speak your thoughts. You will not be able to express yourself. This is why it's called expressive aphasia. Expressive aphasia. We're going to emphasize it a little bit here, and we have a clinical significance which is called aphasia. And the word aphasia literally means without speech, yeah, lack of speech, yeah. So this is the acquired. Remember, this is acquired. Like a person is born with, ability of speaking and understanding written and spoken language, and along the way he acquires this disorder due to the damage of the language centers of the brain on the dominant hemisphere, and the usually on the left hemisphere. We've said left hemisphere is dominant to most of people. Okay, so the key here is language impairment, and in language impairment the patient is having difficulties with verbal expressions, written expressions, comprehensions, or combination, and this will give different types of aphasia. We have different types of aphasia, but we're going to talk about only two types: the Wernicke's aphasia and the Broca's aphasia. And the key here is an ability to use or comprehend words. For example, we've seen in Broca's aphasia the person is struggling to form words, is struggling to use words, and we've seen in the Wernicke's aphasia on the other hand that the person is struggling to understand both written and spoken language. So these are the clinical types of aphasia: the Broca's aphasia, the Wernicke's aphasia, conduction aphasia, transcortical motor or sensory aphasia, and alexia with or without agraphia. And actually alexia means inability to communicate through reading. Yeah, you cannot read. And then agraphia is inability to communicate through writing. So agraphia, writing; alexia, reading. So someone who's alexic means he or she cannot communicate through reading. Yeah, he gets trouble with readings. And someone who's agraphic is unable to communicate through writing. Yeah, so you can have alexia with agraphia or alexia without agraphia. But today we're going to concentrate on the Broca's and the Wernicke's aphasia as the part of the sensory and motor regions of the brain. And it's called fluent aphasia because the person will be talking fluently, like he'll be talking continuously, but only what he's talking does not make sense, because the problem here is language comprehension, understanding of spoken or written language. So you can be talking fluently, but what you're talking does not make sense because you lack the process of language comprehension. Making sense of what you're talking about is actually what is wrong with this. Wernicke's aphasia is usually due to the damage of the Wernicke's area, which is the area number 22, but it can be due to the damage of the common integrative area or the auditory association area. So one more time, these people will have fluent aphasia. They are talking continuously. They are producing the strings of words, but these words have got no sense, and this is called the word salad. They are mixed in words. Yeah. For example, is saying, yesterday the banana jumped over my happiness because the television was feeling sleepy with socks. Yeah, so you see, someone is talking continuously with no breaks, but what he's talking does not make sense. And this is the classic of Wernicke's aphasia. So I have two videos here which are demonstrating the Wernicke's aphasia. I have the English version and the Swahili version. So I'm going to listen to both of them. So this is the English version.
Hi Byron, how are you?
I'm happy. Are you pretty? You look good.
What are you doing today?
We speak with the water over here at the moment. Talk with the people at the dam over there. They're guiding for them at the moment. They'll save in the moment. He'll have water very soon for him. With luck for him.
So we're on a cruise and we're about to
We will store it right here and they'll save their hands right there for them.
And what were we just doing with the iPad?
Right at the moment they don't show a darn thing.
With the iPad that we were doing. Like here?
I got my change for me and change hands for me. It was happy. I would talk with Donna sometimes. We're all with them. Other people are working with them.
Okay, so that's the English version. Let's see the Swahili version. For those who are speaking Swahili, this is actually very funny. I mean, if you are not speaking Swahili, very sorry, but let's hear from this guy here.
Ukisikia neno limbure, wewe unaelewaje?
Naelewa kama ni kitanda ambao umenitandikia na kukaa na kuongea kawaida.
Limbure maana yake nini?
Limbure maana yake usichafue maneno ambayo naelekezwa.
Na unafahamu wajibu wa wazazi? kwa wanafunzi wao kama ili waende shuleni? Yaani mzazi ana wajibu gani kwa mwanafunzi ili aweze
yeye kwa kukicha asubuhi anapanganika, anaenda ndani ya rekodi, anachukua mswaki, anasimamia pamoja. Wenzake wanapokuja asubuhi anawasalimia na kupeana habari kwa kila kazo. Akitoka hapo ndo safari zake kwenda mahakamani.
Una mtoto yuko shuleni? Wewe una mtoto?
Mwenyewe sikumpeleka, labda wampeleke watu wengineo, lakini mwenyewe sijampeleka bado.
I think we can just summarize. I mean, in this video, you can find them in TikTok and or somewhere else. These guys have something in common. They have problems in common. Problem number 1 is to understand what they are asked. And the problem number 2 is to understand what they are talking, themselves, what they are talking. Yeah. So this is the aspect of understanding what you have been told about and then understanding what you are replying. This is definitely what is wrong with these two guys, and that is called the Wernicke's aphasia. Okay, so let's talk about the Broca's aphasia that you've already spoken about it a lot. It's also called the expressive aphasia or motor aphasia, and it's motor aphasia because the Broca's area is the motor area. So you have damage to the Broca's area will cause Broca's aphasia, and the result is reduced language production and the inability to form words because the Broca's area is involved with speech production. And the Broca's aphasia is also known as non-fluent aphasia because the patient cannot talk fluently. The patient usually talking in stops, yeah, they are talking in pauses, and this is because they are struggling to form words, and this makes them frustrated because they understand what they wish to say but they cannot say it. Yeah, you understand how frustrated you can be, that you understand you want to say something but you cannot say it because your mouth cannot let you and your brain cannot let you say it. Yeah, and that is a Broca's aphasia. And of course, if you give them a piece of paper, they can write down what they wish to say and they will understand what they've written, because the problem here is not language comprehension. They understand but they cannot express themselves verbally, and this is the problem with the Broca's aphasia. And for example, people with a stroke, yeah, they face the same difficulties. Like they understand what they wish to say but they cannot say, but if you give them a piece of paper they can write, and that is an example of Broca's aphasia. I have a video here that demonstrate Broca's aphasia. Of course, they're not the classic of the Broca's aphasia, but at least they give you a clue. If you want more videos, you can go through TikTok and write Broca's aphasia, you will see. So let's see an example of Broca's aphasia.
It was actually my leg bag out.
They cannot talk, yeah, so they are not fluent. You can see she's not fluent, like she's talking and then she gets stops, yeah, the pauses. Let's see another. Have you had it? Let's start again. Have you had it? Let's see how she struggles to get the words. Yeah, she's struggling to form words.
It was actually
not you. This one. Not you. This one.
Breathe.
Have you heard it? Let me start it one more time. So listen how she struggles to form words. Yes. Have you heard it?
Breathe. I did it once today. You had water today. I didn't think it was.
You see, they understand what they wish to say. They can only not say it, yeah. But if, of course, with the time, with the speech therapy, they get better and better. But yeah, at least you can understand. They become frustrated because they understand. I want to say something, but why can't I say it? That's the Broca's aphasia. Different from the Wernicke's aphasia, the person is actually happy, talking fluently, happy. There's no obstacles while he or she is talking. Okay, so have side-by-side table here to compare Broca's and Wernicke's aphasia. The main lesion, Broca's area, the main lesion, Wernicke's area, Bodman area, 44-45, Bodman area, 22. The fluence of speech, this is non-fluent, of course, this is fluent, and they usually have excessive talking, which is called logorrhea, as just I've told you, and they are talking fluently. Yeah, so the speech output is reduced in Broca's aphasia, but in Wernicke's aphasia, the speech is normal or increased. They have increased the volume. And just to summarize, the main typical region is caused by the infarction of the superior division of the middle cerebral artery. We're going to talk about it later. But the venous aphasia, if it's due to stroke, then it's due to infarction of the inferior division of the middle cerebral artery. All right, guys, if you have question, additional comment, then you can always reach by. You have TikTok and Instagram. See you really soon. Bye bye.